Hello, everybody. If you'd like to take a seat, please. We're going to kick off the debates. So we have a first discussion this morning between Jean-François Bergmann and Jean-Luc Arousseau, moderated by Jean-François Lemoine, and the theme of that is between the freedom to prescribe and the need to regulate, what should we be doing? So this will interest my colleagues in particular. So if you'd like to come up onto the stage, those three speakers. Thank you. Hello, everybody. Thank you for coming here so early for the debate. Now, I am a doctor by training, but I'm a journalist at heart. And when the news joins the theme of this morning, I'm very happy. So between the freedom to prescribe and the need to regulate, well, the need to regulate prescribers and drug companies have been very busy in terms of the cholesterol medication. As of the 1st of November, doctors will have to put forward a request to the Social Security system. Now, the measures contested, concerning cardiologists and doctors. So who was aware of the publication of these measures? Well, I'm not sure that everybody was aware, but anyway, I'd like to thank the director of the health insurance company for the present with respect to the theme of this round table discussion. You know, when there's a problem, when there's a crisis, we always try to have specialists. Now, when the French army is somewhere, for example, we always bring in a retired general to explain what we haven't understood. And we are lucky enough to have the general with us today. He's to my left, Jean-François Bergmann, who is the expert on medication. He's been freed of his administrative functions. He was vice president of the Transparency and Notices of Compliance. So he's here to give us his liberal crypto-Stalin-based words on the theme. To my right, I have President of the High Authority for Health. Maybe she should be in the center of the table. We always forget Jean-Luc Arousseau, that Jean-Luc has an international expertise. He's somebody who has traveled a lot. He's been to the Milhomme. This is somebody who is extremely competent. Jean-François Bergmann. Now, the statin, what do you think about it with all the things that are being said? We're going to find a clear, simple solution. But things have been very opaque. Licristo, Juvastatin. Maybe we could talk about a non-medication. We'll have a look at the mortality studies in a few works. Apparently, statin is good. What I suggest is that we bring down the price of statins. That will help us to make savings. And then we bring out the Etimebs. Now, I was having lunch with somebody who's in charge of health insurance, and he said it's not as easy as that. Well, I don't know about that. Anyway, setting up a prior approval, waiting for the opinion of the Social Security Department before we prescribe a medication that we believe is good. If it's good, why not prescribe it to everybody? But maybe it's a measure that Jean-Luc Rousseau had up his sleeve. Maybe it's something that you were planning to do anyway. What do you think? Because when we're talking about the freedom to prescribe, it seems to be rather provocative, this idea. Well, first of all, thank you for saying that I'm a centrist. I would say that I'm more of a moderate. Not soft, though. Well, that's your vision of things. I would say you're more of a centrist. Is Bourlot somebody who is soft? No, of course he's not. No, he's a politician as far as I know. First of all, I think we need to put the decision in the context. Why was the decision taken? Well, first of all, because of the economic problems, because of the fact that there are MPs who are acting as police. We need to make savings. We're all expecting structural reforms, but it's much more difficult to implement than imagined. You've got to organize healthcare. It's much more difficult than to bring in rebates in different areas, which means, basically chopping off ill branches. So we're looking at 15–16% of health expenditure for getting medications out there on the market. Now, we're going to be cutting off the branches by dropping prices, 1 billion per year in savings. And there's another measure that is not usually used for medications. We're going to be focusing on prescription. Why is that? Well, France is very particular. We've got great molecules, but they're expensive. So they're not authorized in several countries in Europe, including Germany. So 30% of the statins, Le Crestor, in the main European countries, they count for 6 or 7%. So in 2010, we carried out a medical and economic evaluation of statins, and we decided that this specific type of statin was not efficient. And in most cases, Bravastatin, Simvastatin were enough and were therefore more efficient. This is what you said 2 years ago. I'm talking about 2010. So we'll talk about it again. You said this 2 years ago, and 2 years ago, I'm hearing you saying the same thing. Well, I'll give you some examples of the recommendations of the High Health Authority, the High Authority for Health. We haven't been listened to. So we were expecting for the ASMS. Now, there was a colleague who talked about bookkeeping expertise. Now, here we're talking about medicalized expertise. We're talking about doctors who looked at the cost and efficiency ratio. It's not a question of saying it's too expensive. It's a question of saying that the cost efficiency ratio is not good enough. I think that we've got to follow the recommendations. Up until now, we haven't done enough education in terms of efficiency. It's a notion that we have to educate people about. But in the long term, we're not talking about other classes of medications that are targeted by this measure. What do you think about anticoagulants, for example? So, well, certainly, yes, they're bigger than what we have been referring to, which is a non-drug. Now, and we're not just talking about medication. There are prescriptions of medical acts. In particular, the authority is focused on the dosing of vitamin D. That dose has been increased by a factor of 10 since 2005. Often the prescriptions are pushed by the patient because they've read in a magazine that it's a good thing to take vitamin D. So the dosing has multiplied by a factor of 10. So we've published recommendations about its use. Now, the Health Insurance Department translated that into a measure, asking doctors to specify that it was in the framework of a reference system. Now, we're being taken onto a field that says something different from the theme. So let me cite Jean-Paul Ortiz. He said, soon we'll have to ask the insurance to ask us to ask the insurance companies to give us permission to do medical acts. Now, prescribing is a fundamental act of medicine, no? Today, there are there are 80 patients a day. We're allowed to go to zero further training. We're allowed to practice until we reach the age of 18. We're allowed to do all kinds of things. You're talking about entitlement, but what about the conclusion? So we're beginning to work on further education and certification. After that, we can think about freedom. What about getting rid of the freedom to prescribe? People are worried about that, but you're not. Now, There's you can refer to North Korea as well. So I went to see them on Wednesday, and I said to the team, what should I say to them on Saturday? So I went to talk to the interns, to the external doctors. So 9 girls and only 1 boy, so average age 30 years. So it's great, a great environment. So, and I've learned that he classifies journalists according to their appearance as well. Anyway, these young ladies who are future doctors say we must get rid of the freedom to prescribe. The problem is that policymakers, well, are too old, and that's the problem. Women, the doctors of today and tomorrow, they agree that we need to have more of a framework for prescription, a fairly authoritarian prescription. You talked about Germany early on. This freedom, is it a French exception or what? Well, I'm a hospital doctor. I've never worked in the private sector, but I like to defend general practice. It's something that the French are very much attached to. And I'd just like to remind you of the 5 principles of general practice. Free, the doctor can choose freely to work with patients. There's privacy, direct payment of fees, and the freedom to prescribe, and the freedom to set up wherever. Now, this freedom consists in doing everything that doesn't harm anybody else. I think things are changing. We mustn't harm other people. We mustn't take decisions that harm our patients, in other words. Globally in France, doctors do their job well. Doctors do their job well in France. 2 years ago here, there was Victor Rodwin who came along and who talked about mortality and talked about healthcare organization. We're still the first for this. The problem that we have, yes, we are the first, not for everything, but we're the first from that point of view. What I think is that harming other people is tantamount to harming society. And doctors' decisions, well, have to take into account that it's important what I have to say, but you're describing something different. Anyway, these decisions involve choices because the budgetary envelope is smaller and smaller. So those who spend too much in one area, on statins, for example, will be able to spend less on the development of innovation, new treatments for hepatitis C, for example. So it's harming society, it's harming the durability of the French social system. So we haven't been trained for that. The 2 of us, we haven't been educated for this kind of theme, savings and economies. So you want freedom to prescribe. So you're painting to us a very lovely world, but so what? So we mustn't harm other people. But how do we get organized? The theme is freedom to prescribe, but necessity to regulate. So is it the high authority for health that should be taking all the decisions? So our role, let me ask you the question. So the answer is yes. Now, how are best practices drafted? So you're a little bit behind in terms of technology. So we hear, let me just give you an example. I've been thinking about both of you this summer. I had a sore throat, and so my wife said, no, you won't be taking any corticosteroids because that's not a good idea. You could have taken antibiotics. No, I was talking about corticosteroids. So I looked at the blogs and on the web, and there's a kind of politically correct attitude in terms of what we should be doing when we have a sore throat. Haven't we got to the end of all of that? Now, the question is, how can doctors, by keeping their freedom to prescribe, how can they take part in the regulation? Now, obviously, we have to follow reference systems. We're not the only ones. And I think that doctors have plenty of information. They can have information from applications, from internet. But the question is having the right kind of reference systems, the most suitable and up-to-date reference systems. And our problem is that with the means available, and there are less and less of these, we're finding it difficult to follow current medicine. So we have to work more and more with professionals, with scholarly societies, making sure that there is a kind of medical monitoring system so that doctors can work according to best practices. But there is a big difficulty that we have to face. You know, how can we be legible, so to speak? In the past, we published 150 pages, but doctors don't have time to read that. So recommendations today have to be very simple. They have to be kind of just memo sheets, if you like. So yes, we are there to give recommendations. Now, the authority always talks about things without taking into account other areas. Yes, we're not well known enough. It's true. There was a debate about the choices of users. We didn't talk about certification of health establishments and the health authority. No, we're not talking about advertising. We're talking about information. These two things are not the same. Now, when we prepared the debate, both of you were very much a Third Republic. So the credo should be the pride for doing things properly and looking after patients. Now, both of you said this. It's lovely, but what do you mean? When you have a viral authority infection, corticosteroids always work on the 7th day, but usually they only last for 8 days in all. So I can hear you being dogmatic again. But what happens when you can't swallow anything? And you talk to a friend and he says, take corticosteroids and then you can swallow. Well, there are strepto tests that can be carried out, and these might be negative, which means that there's no streptococcus, and you take corticosteroids, and then when you have a sore throat, later on it's more complicated. So I'm sorry, the speakers are speaking at the same time. It's very difficult to interpret what they are saying. So you have to be well trained. You have to continue to follow training. You have to have a reference system. Have you already been onto the medicament.gouv site? You go on once, you don't return. It's the same thing of the HAS site, the High Authority for Health site. So both sites are difficult. You've got everything on another site in English. The British formulary, 13 people, an edition every 6 months. It's something that's updated. Now today, unfortunately, France hasn't got a French formulary of a list that would act as a reference that is updated every 6 months, that would be a good document, and that would code any kind of acts in general practice. So we would be able to know what GPs are doing and correlate what diagnosis is being carried out and the practices. So we've got to be good. What about these references? Are you more for a carrot or a stick? Well, a bit of both, and then some love. So he's the centrist, not me. Some love, he's saying. Yes, I want to be Stalin. So now, we're going to give you a lesson on centrism now. No, recognition works, but it has to be done intelligently when doctors get together, when they talk about cases, when they take decisions. Evidence-based medicine, it's not just about evidence, it's also the wish of the patient. And that's why our job is so subtle. If we don't frame all of this, if we don't structure all of this, and I'm insisting on the coding of diagnoses that orders of doctors hate, that unions hate, because there is a certain mediocrity in some practices. So coding, if we see okay, he's here because he's got a sore stomach. Diagnosis gastroenteritis, prescription Motilium, Turfan, Augmentin. Well, then that person should be sent to the gulag, that doctor. So I'm great to see that the audience is applauding this Stalin follower. No, he's from North Korea. He follows Stalin. No, what do you think anyway? So this is a very important question indeed. We've got 3 means to make sure that doctors follow the reference systems. The first means is checks and sanctions. This is something that was done in the past already. I won't say what I have to say about that. I wasn't really in agreement with it. It is a means that used in other countries now. The second means is that which is used today, and that is based on financial incentive. So remuneration in exchange for the reaching of medical objectives. Financial incentives to improve quality in healthcare establishments by the GOS. In France, we are setting up this kind of financial incentive. What should we expect from it? Well, there are other countries that are ahead of us. Well, England, for example, the United States, all Anglo-Saxon countries have set up financial incentives. They're called pay for performance, P for Ps. And publications show that the results in terms of indicators, health quality indicators, and even mortality indicators are fairly modest or variable. But basically, that's not the objective. And correct me if I'm wrong. The aim is to make sure that there isn't practitioner remuneration based on acts only. There has to be diversification of remuneration modes, focusing more on quality. That really is an upheaval in the way you work. Yes, but I think that the medical unions would be in agreement about that. Now, the third means, and this ties in with what our Stalin follower has been saying, we can make sure that information and the dissemination of this information can help professionals to do the right acts, to use medications properly and to carry out prescriptions properly.
How can we do that? Well, if it starts from the top, if it's something that's imposed on them, then it doesn't work. So for it to work, it's got to be something that we do with the professionals themselves. And that means that all the publications, all the documents we edit have to be done with them, disseminated by the medical council and so on. And I'm not a specialist. I could perhaps do quite a lot with them. And I'd like to say that I acknowledge, like Professor Bergman said, that a lot of the prescriptions are really stupid. But sometimes when the professionals get their act together, things do work. And let's take myocardial infarction, for example. The practitioners have an indicator, a best practice indicator when people leave hospital after myocardial infarction. It's based on some very basic things, tables, anti-aggregation tables, for example. And it's based on indicators of quality of health, and it works in 85% of the cases. But it so happens that mortality by infarctus in France are on the basis of the OECD report. We're the second country. We rank second in the world. Isn't the future machines? Do we use all the means that we have, all the smart systems that enable us to help us in what we do? No, I think real prescription is going to be done by the brain. It's easy to make a diagnosis by a machine, but when you have to take a decision like that, a prescription is something that's individual, but there are standards. Let's go back to what Mr. Rousseau was saying. When you have somebody who's really involved, when you see that 20% of the patients die of cancer in hospital had chemotherapy 15 days before, you've got patients who are dying from pancreatic cancer, cancer of the pancreas. Well, you had a very high position. Why are you not in it anymore? Well, because well, a lot of solutions that are close to hand and are not applied. Well, because there were a lot of imbalances, because you can't do this, because you can't scare the pants off everybody. It's very easy to work out reference lists, but or measuring sticks. Well, unfortunately, I do X-rays, and I always finish my broadcasts with 20 seconds each to conclude. And the advertising comes afterwards, of course. Well, machines are essential. For example, information systems are example. They're absolutely essential today. You cast that aside, but the doctors have to be able to carry out their activity. They need messages, and we work on very simple data. We call them data sets. And these are systems in which the doctors enter simple data, and they can get information concerning warning signs to help them. We've certified these warning signs to help them to prescribe the right drugs, and they use them. The problem we're talking about is the issue of the relevance and efficiency of what they do, of the procedures. And the doctors have to be able to write out prescriptions that are relevant and efficient. Well, I think the doctors are quite prepared to have a framework to help them to prescribe, but you've got to tell them that we have to, they do have the right to use some rarer drugs, and they'll do it, except that they're scared of doing it now. Well, I don't think we've said. We spend our. Well, what do you think about the freedom to prescribe? Well, thank you anyway. Thank you all very much indeed. Give them a round of applause. That's fine.